Great lineup for this year, and hope you'll be joining us for some of our future events, which include topics such as seeing double, pediatric ophthalmology, a collaborative lecture on eyes and sleep, the relation between dry eyes, sleep apnea, and its connection to dry eyes and saggy eyelids, and a bit about sleep apnea from our colleague, Dr. Kevin Im at the UCI Medicine Sleep Center. We also have a collaborative lecture scheduled on diabetes, diabetic eye disease, what it is and how it's treated, and dietary management of diabetes with our colleague, Dr. Quinn Yang from the UCI Diabetes Center. And we also have a talk about annual eye exams and new lens technology from our optometrist, Dr. Liegler. You can visit our website, www.uci.edu, to find more information and to register for those lectures. You'll also be able to view videos from previous lectures in case you've missed any. Tonight's Zoom lecture will be recorded and posted on our website in the coming weeks. We'll send a link to the recording to everyone who's registered to attend the lecture. Tonight, you'll be hearing from Dr. Andrew Browne, who'll be talking about age-related macular degeneration, changes in vision, and long-term prevention. Please feel free to put your questions in the chat, and you can save them till the end of the lecture when Dr. Browne will field your questions. Thanks again for joining us. Enjoy the lecture, and now I'd like to introduce Dr. Andrew Browne.
Hello, everybody. I'm just going to share my slides here. And can you see those okay?
Yes, we can. Thank you.
Perfect. Great. Well, thank you, everybody, for your time to come and chat with us this evening. Tonight's topic is age-related macular degeneration as part of our community outreach series. And I would like to thank Dana Collinson for coordinating and arranging the series for us as clinicians to be able to interface with patients and help to give patients in the community some more information about the diseases that they come to us for their care. So today we'll be talking about age-related macular degeneration, and we'll just dive right in. So when you think of a photograph that's taken by a camera, we see a picture here where everything is nice and uniformly sharp from the central part of the photograph to the peripheral parts of the photograph. So at the edges of the photograph, everything is equally sharp as in the center. And the eye is like a camera in how it forms an image. There are lenses at the front, what you could consider the cornea, and the lens inside the eye that focus light onto the retina inside the eye, the film in the camera or the digital sensor in a camera. And so the camera makes an image like this, where we've seen that it's uniformly sharp across the whole image. The eye, like I've described, has a cornea at the front of the eye where light enters the eye and is focused by the cornea and the lens to go all the way to the back of the eye onto the retina. And the retina is drawn as an orange line in this picture. All the information in the retina is generated by light touching it. So the light that touches the retina is turned into electricity that is sent back through the optic nerve here in green to the brain, and the brain perceives vision. So the eye itself is a focusing and light sensing instrument that conveys information to the brain. However, the retina is not exactly like a camera because not everything is equally sharp across the field of view. And I'll zoom in here on this picture. You can see that in your central field of view, you have the sharpest acuity vision. And then as you go further and further to the peripheral parts of your visual field, things are more obscure. And so that's why we read and see faces with the central vision, and we use our peripheral vision to see things moving like cars. So the central vision is provided by something called the macula, as we will see shortly. And the peripheral parts of the vision are provided by the peripheral retina. So just to kind of cover some of the conditions that affect the aging eye first, I won't be talking about these in detail, but I just wanted to give them in terms of providing a context to differentiate them from macular degeneration, which is the topic of this evening's talk. Presbyopia is the condition that starts to affect people around the age of 40. And I'm starting to notice that myself, being that I'm 42. I can't see things up close as easily as I could when I was younger. And slowly I know that that process will continue, and I will have to have some reading glasses to help aid my cornea and my lens to see things that are up close. Dry eye is such a common condition, especially in Southern California, where the climate is quite dry. It's basically the tear film on the surface of the eye is of a lower quality, so it evaporates more quickly. Cataracts are where the lens inside the eye gradually becomes less clear, more opaque, and the amount of light that enters the eye becomes much less, darker, or it can be scattered or become blurry. So the lens apparatus from affecting the cornea and the lens inside the eye, this whole apparatus is affected by dry eye, cataracts, and presbyopia. Glaucoma is a condition that affects the optic nerve that sends the information back to the brain. And this is also an age-related condition, although it can affect people in younger phases of life as well. And then finally, age-related macular degeneration, the topic of today's talk, affects this very small central part of the retina at the very back of the eye that provides the sharpest acuity of vision. So looking at age-related macular degeneration, or AMD or ARMD, if we break it down, we can get a sense of what it is. Age-related, it typically occurs as people age. Once you are over the age of 60 or 65, if you have a predilection for it, if you have a higher probability of getting it, that's when you might start getting it. Macula, it affects the macula, the central part of vision. And degeneration, it's a change from normal to lower function. And fortunately, macular degeneration is actually, age-related macular degeneration is quite a slow process in many cases. In fact, that's why it starts in an age-related fashion. It takes several decades before it actually can start to have any impact on vision. So coming back to this image of what the eye would perceive, we have the central vision, which in macular degeneration, the contrast sensitivity declines. So basically, the central vision can look a little bit more like this over time, where it's harder to read in your central vision than it was when you were younger. So as you can imagine, under low light conditions, as simulated in this picture on the left, it's harder to read the signs on this freeway board. Whereas under bright light conditions, it's much easier because there's higher contrast in the letters on the board. And as age-related macular degeneration progresses, we can see that in this image on the left now, we can't read any of the letters, where on the right, under bright light conditions, we can still read the letter San Diego. So for people who suffer from macular degeneration, you might be told that you're 20/20 and that maybe you should be happy. But the reality is 20/20 is a measure that we perform routinely in optometry and ophthalmology clinics to quantify how much vision you have. It's measured by reading black letters on a white surface. And so we can gradually decrease the size of these letters from 20/25 being the second most common line, one size larger than 20/20. But basically, this is the most commonly used tool to actually measure a person's visual function. Under low light conditions, if you have perfectly clear vision, it's not too difficult to read the letters in the chart. However, if you do have a decline in your visual contrast sensitivity, you can see that these letters become much harder to read. However, macular degeneration actually can cause some distortion of letters. And so we see that we can still read the letters and identify what they are under high light conditions, but it is much more difficult. And so this loss of contrast and possible distortion that people experience is why you can still be 20/20, but the quality of what you're seeing may not be what you would describe as 20/20 vision. And certainly as contrast goes down, even with distortion, reading the letters becomes even harder. And then under low light conditions, reading distorted letters becomes even harder as well. So how do eye doctors examine the retina? I've told you how we measure visual function primarily is the visual acuity test, reading letters on a chart. But we can also take photographs of the back of the eye. So we can look in from the front of the eye through the clear cornea and the lens to look at the retina. And we can take a photograph like this. This is a 200-degree wide field image. It actually takes an image of the retina beyond just the 180 degrees. It actually can see a little bit beyond the 180-degree meridian. It's a very wide field image. And I'll blow this up. Here's the central vision here. This is where the fovea is. The macula is this region here in the center. And this is the optic nerve. On the surface of the retina are all these blood vessels. And these blood vessels go all the way out to the periphery. So the central macula gives you central vision and the peripheral retina gives you peripheral vision. And all this information dives into this tiny little 1.5 millimeter optic nerve with, at the beginning of life, 1.2 million axons or nerve fibers going back to the brain. Actually, half of the information that goes into this optic nerve comes from this tiny little area here in the center of the macula. This is the fovea. In the last 15 to 20 years, another technology has emerged that has really revolutionized the way that we can provide care to people with all types of retinal diseases and even cornea diseases, diseases at the front of the eye. But we're focusing on the back of the eye here. If we look at the back of the eye, we can see the optic nerve here, we can see the retina in orange, and there's a green foundation underneath the retina, and there's actually blood supply underneath that foundation here in red. So we have blood supply on the surface of the retina, and we have blood supply underneath the retina. And if we zoom in even further, the technology that allows us to see with very high resolution information is called optical coherence tomography, or OCT. And so this is actually an image of a patient seen in the clinic. This is inside the eye. This is the vitreous jelly inside the eye. And on the bottom of the picture is outside the eye. We can see the optic nerve going back towards the brain. And this is the fovea. This is the normal appearance of the central part of one's vision. We can see this bright white line underneath the retina everywhere. That's the foundation of the retina. We call it the retinal pigmented epithelium. And it's the interaction between the cells at the bottom here, called the photoreceptors, and the retinal pigmented epithelium, this bright white line, that are damaged in the course of age-related macular degeneration. So the cells that down here, the photoreceptors, are supposed to be able to turn light into electricity. But if those cells are damaged, then the light coming into the eye can't be converted into electricity, and no signal would be conveyed through the optic nerve to the brain. OCT is an incredible technology because we can actually see the individual layers of the retina, not quite at the same resolution as if you cut the retina out and put it onto a pathology slide and looked at it with a microscope, but quite close. This is actually a pathology specimen of a retina, and we can see the layers align themselves on the OCT with this pathology slide. The retina actually has got two main layers, the blue layer up here and the green layer down here with this foundation underneath it. And we can see that there are multiple different cell types that make up this retinal layered structure. Here are the pigmented epithelium underneath the retina, and here are the photoreceptors in green. These are the cells affected by macular degeneration. And these cells are all provided blood supply from underneath the retina. The choroidal vessels underneath the retina give blood supply to the green and magenta layer, and the blood vessels on the surface of the retina give oxygen and nutrients and blood supply to the blue layers of the retina here. So we can see that there are different layers of the retina, and we can see that in a healthy eye, this is the appearance of a photograph in the back of a healthy eye. And this is the OCT image of the healthy eye. In diseases like macular degeneration, the photoreceptors and the retinal pigment epithelium are damaged, and we can see a photograph here of advanced dry macular degeneration. We can see how there's changes in the pigmentation. You can see what we describe as a scalloped border around this area of what is actually atrophy. And on the OCT, this high resolution laser scanning image, we can see that there are certain layers of the retina that are actually missing in this patient with advanced macular degeneration. We see the foundation over here, but there's no foundation over here. There's actually just the bedrock layer that we can see here is this bright white line. And so in these areas, like over here and over here, the vision is lost. Over here, we see some normal bright white layer, and so there probably is some vision here. So this person may still be 20/20 or 20/25, even though they probably can notice some significant decrease in their vision. So age-related macular degeneration is broadly classified as dry and wet. On the picture here, we see a house falling into a sinkhole where the foundation of the retina has atrophied, and the retina in this case being the house has fallen into that atrophy. Wet macular degeneration is where the foundation can be flooded. And so everything about macular degeneration is about trying to maintain the foundation of a house. And ideally, We would like to be able to take a broken foundation and convert it back to a normal foundation with good structural integrity so that the retina can perceive light and provide vision. When we talk about macular degeneration, I describe it as being a degenerative process, a slow degeneration that takes decades, usually around in the 60s when it can start to appear, could start to appear even earlier. But in the earliest form of macular degeneration, when we look at a photograph of the back of the eye, we can see these little yellow dots, and these are what we call drusen. These are bumps underneath the retina, and they're made up of waste products that occur just because of natural vision. Vision is a very energy intensive process for cells to be able to perform. To take light and turn it into electricity requires a lot of energy and a lot of very special proteins and chemicals that can allow that process to occur. When light is turned into electricity, those chemicals and proteins, they have to recycle very quickly so they can continue to provide vision. And so the breakdown products, the waste products of vision, are basically what we call drusen, or bumps underneath the retina. In fact, these little yellow dots or bumps under the retina called drusen comes from the German word for druse or bump. As macular degeneration progresses from its early to its intermediate phase, the bumps can become larger and more plentiful. And when we look at the OCT, if we compare a normal OCT image to the intermediate age-related macular degeneration, we can see larger bumps underneath the retina, and they can become more plentiful. Of course, as the generation progresses, the foundation can break and new blood vessels can grow up from underneath the retina and cause bleeding or leaking in the retina. And so we see in this patient's picture, there's blood underneath the retina, and it's kind of splotchy in different places. It's all the way underneath the retina. We can see through the retina and we can see the blood underneath it. And there's also some scar material that's starting to develop underneath the retina. And if we again compare the normal OCT with the wet age-related macular degeneration OCT, we can see that there's large dark pockets that we call fluid in the retina, and there can also be fluid underneath the retina. And we can also sometimes see some darker areas associated with blood. And so we do have treatments involving intravitreal injections into the eye to treat wet macular degeneration. And I'll talk about that a little bit more later. Wet macular degeneration is one of the versions of advanced macular degeneration. We can also have advanced dry macular degeneration. And you've already seen this picture earlier where we saw the atrophy in the central part of the retina. And if we compare the OCT, you can see from this picture that you saw earlier that the outer retina has had atrophy and there is some cell loss causing vision loss. There are treatments that are coming on the horizon to slow the rate of growth of these areas where the cells have died. And I'll talk about that later too. So how can patients monitor macular degeneration? Well, home monitoring at present and for many decades has relied on something called the Amsler grid, where a patient closes one of their eyes and they stare at this little black spot. And then they use their peripheral vision without moving their eye around to observe the spaces, the grid around the central black dot. And in macular degeneration, people might start to observe distortion, a dark splotch or a very dark splotch in different areas. They could have distortion with darkening as well. So whenever the Amsler grid, and when someone's using an Amsler grid at home, if they notice that there's a change from normal to something that looks like one of these other images, then we encourage them to come in as soon as possible to be re-examined. Of course, if you've been examined and your Amsler grid looks like this, and it changes from this, then we'd want to see you also again to confirm that there aren't changes that are occurring from macular degeneration that can be treated. One of the more recent ways that people can monitor themselves at home, it's very similar to the Amsler grid, but it requires an appliance that you keep in your home, and it has a test that you look inside the apparatus, and there's a central dot, and you look for a wave in the line. And so some people have used this as a home monitoring tool, but it does require storing an appliance in your home. But it can pick up subtle changes in your vision. One of the more recent developments is something called home OCT, where you'd again have an appliance that looks like this. These are not widespread yet. They've been in clinical trials, and it has shown some promising results for home screening. And if you compare the home OCT image here with the clinical OCT, you can see the similarities. And so these technologies may start to become more commonly available for people. The clinical trials are still required to make sure that they actually do improve care and improve our thresholds for seeing patients. We want to make sure that if we have these ultra high resolution technologies, that we don't sound the warning signs with too low of a threshold. In other words, we don't have people coming in more frequently than they need to be because the machine provided an erroneous report. But these machines actually are very good, and they are going to be driven by artificial intelligence to help to identify changes or abnormalities. So this may be the future, depending on how efficacious they are in the clinical trials. So in terms of managing macular degeneration, we can talk about prevention. We have modifiable and unmodifiable risks. Modifiable, the most important one possible, is cigarette smoking. If anybody smokes cigarettes, they should try and reduce the number of cigarettes that they smoke on a daily basis. If they can go to zero, that's ideal. Cigarette smoking is known to cause a host of medical conditions, but it definitely accelerates the formation of macular degeneration and its progression to advanced macular degeneration. High blood pressure and hypercholesterol and heart disease are loosely associated with it as well. So making sure that these are controlled properly, high blood pressure, high cholesterol, heart disease are all managed by your primary care doctor. Making sure that they're completely controlled will also have a positive effect on controlling macular degeneration. Unfortunately, there are unmodifiable risk factors like family history, having hyperopia or a prescription that makes it so you really are dependent upon glasses, light irises, so blue and green iris color, and actually females have a higher risk of macular degeneration than males. So we can't modify those risk factors, but we definitely can modify, especially cigarette smoking. Then there's also just try and slow the progression. And so I'm going to talk a little bit about the AREDS vitamins, which were supported by a large NIH-sponsored clinical trial. And also more recently, information that's come out of the AREDS studies that are supporting Mediterranean diet. And finally, there are therapies that involve injections or even lasers, but the lasers are used much less frequently nowadays. These are more what were the mainstay in the 90s and early 2000s. So first off, in terms of prevention, there were these two studies called the age-related eye disease studies, numbers 1 and 2. Number 1 occurred from 1992 to about 2005, in which there were hundreds of patients, actually I think a couple thousand patients that were enrolled, and they were either given a vitamin cocktail or they weren't given a vitamin cocktail. And then from 2006 to 2018, a very similar study was done called AREDS 2, and they were patients that were enrolled in the study were provided a slightly modified version of the AREDS 1 cocktail called the AREDS 2 cocktail, and I'll talk about that here in a second. In AREDS 1, patients were given vitamin A, vitamin C, vitamin E, zinc, and copper in the cocktail, and it was found that this slowed the rate of progression from intermediate to advanced forms of macular degeneration. There was no benefit for early macular degeneration in slowing it down from progressing to intermediate macular degeneration. In AREDS 2, they asked a very important question, is can they get rid of vitamin A? Because people who have a history of smoking, when they're on vitamin A, beta carotene for extended durations, they can have a higher risk of developing lung cancer. And so in AREDS 2, they sought to eliminate the beta carotene component and then add lutein and zeaxanthine, and also to look at omega-3 fatty acids or fish oils. And they found that the modified cocktail, getting rid of beta carotene and adding lutein and zeaxanthine, was equally efficacious, equally effective at slowing down the progression of intermediate to advanced forms of macular degeneration. The ARED studies were fantastic because they were conducted incredibly thoroughly. They had thousands of patients that were monitored and followed over 6 to 10 years. And they, at the beginning of the studies and throughout the studies, they monitored the patient's dietary intake. And so what they were able to identify was that a Mediterranean diet, while we know fully well that a Mediterranean diet is really superior for cardiovascular health, they identified that people who consumed a large amount of fish and seafood, basically twice a week, is considered a high fish consumer, and people who consumed a lot of whole grains and nuts also had a benefit in slowing down the progression of macular degeneration. And if you look at the Mediterranean diet and you compare it to the Western diet, this is the food pyramid for the Mediterranean diet. They eat lots of fruits, vegetables, cereals, whole grains, preferably in olive oil, nuts and seeds, and also fish. Everything's upside down with the Western diet. So if you have a very heavily Western diet and you have macular degeneration, try and do the opposite of that. Try and have as much fish as you can and replace red meats, and try and have whole grains and nuts as well, because these two things really have shown benefit. So let's just come back to slowing down the progression. We have a healthy eye that can progress to early macular degeneration. It's hard to see in this picture. There's a few little small dots. In the intermediate macular degeneration, you have larger yellow dots or bumps underneath the retina. And then an advanced form of macular degeneration, we can have geographic atrophy or atrophy of the central retina, or even new blood vessel growth. The AREDS vitamins really had no benefit in healthy or early patients, early macular degeneration patients. However, there was a benefit for people with intermediate and beyond macular degeneration. The Mediterranean diet, however, has a benefit throughout. It slows down the progression of early to intermediate or from healthy to any of the advanced forms. And so it is a really important adjunct or additional approach to slowing down the progression of macular degeneration. So what about people who develop wet macular degeneration? This is where you can have bleeding underneath the retina or fluid within the retina. And so we can see the OCT here on the right-hand side. There's fluid underneath the retina. And after treatments of injections into the eye of different medications, and at right now, there are 5 medications that have been approved by the FDA. Macugen is really not used any longer. But these other medications are. There's another medication called Avastin, which is not FDA approved. It is in the same family of drugs as these medications. Avastin is used for cancer therapy, but it is used in an off-label or non-FDA approved manner, the same way that these other injectable drugs are used. And so you can see that when you inject one of these medications into the eye, you can have the blood can go away because the bleeding is stopped. The fluid underneath the retina can go away, and some normal vision can be restored. So these medications have completely revolutionized the way that we care for patients with macular degeneration. In the old days, in the 80s and 90s, if someone had bleeding underneath the retina, well, I wasn't practicing back then, but retina specialists used to use lasers to burn the retina to try and kill the new blood vessels that were leaking and bleeding. So people inevitably lost vision just from the therapy that was intended to try and prevent additional vision loss in the future. So nowadays, the use of injectable medications into the eye are really quite revolutionary. And the most recent one that was FDA approved is something called faricimab. The goal of it is very similar to the previous ones, except hopefully it requires fewer injections over time than the other medications. So injections for wet AMD. Somebody sent me an email before this talk asking, how do you know how many injections you need or how frequently you need to have injections? And everybody's different. What I like to show here is, let's pretend we're talking about 12 months in a year. If someone, and we're talking about how active is someone's disease, how active is their active wet macular degeneration. If they're very active, people might require an injection every single month, maybe 8 or 9 times in the first year. And then they can start to require a few injections over time. So a lot of providers will try this approach where they will keep on injecting until they get a complete response. And then they will start to space out the injections until we get to 3 months between injections, and then continue to monitor. We always will monitor somebody every 3 months or so, maybe 4 months if they've been very stable for a long time. If someone has a medium activity disease, they might require a couple injections month to month, and then before we can start spacing out. And if someone has low activity disease, maybe they can be spaced out very quickly. So there's no right answer or there's no definitive answer for how many should an individual person need, or how can they predict how many they need. It comes down to evaluating them after an injection to see how well they've responded, and determining if they can come back less frequently. Some other retina specialists, and this is a very common practice as well, it's very favorable because patients can be seen every month. And that way, if patients are concerned about being tracked on a monthly basis, they can come in and be tracked every month, and then the decision made at every visit if an injection is needed. Some patients are really opposed to this because it does require an injection, a visit to your retina specialist every month, as opposed to someone with low activity disease that might come 5 times in a year rather than 12 times in a year. So a lot of, and I would say the majority of people in the United States do this type of therapy where they try to space out the injections over time and minimize the number of visits that patients come for. Another therapy that has recently become available is something called Susvimo. It's actually an implant. You have a surgery to put this plastic pellet-like structure inside the eye, and it's actually a reservoir for another medication, Lucentis. Lucentis is the only medication that has been FDA approved for use in the Susvimo implant. And so basically every few months, maybe 3 to 6 months, there might be an injection or a refill of the implant. But this does, of course, require surgery. But the idea is hopefully to reduce the number of visits that are required to control macular degeneration. People should still be monitored to make sure that that the implant is sufficient to control the activity of their wet macular degeneration. And finally, for dry macular degeneration, we've been talking about wet macular degeneration in terms of injections, because these injections can slow down blood vessels that leak and actually make some of the blood vessels go away. In dry macular degeneration, we've talked about the cells that die in the foundation of the retina. And so we see in this picture here on the right, these dark areas are areas where cells have died. And over a period from 2004 to 2008, that area can expand. And so the goal has been to try to develop an injectable medication that can slow the rate of progression of this dark area. And so these medications, there are some medications that have shown significant promise in clinical trials. They are not yet FDA approved. They are not yet clinically available. But I anticipate that someone in 2004, like this picture here, in 2008, rather than looking like a large dark area like this, they might look more like they would have looked in 2005, with the medication slowing down the progression of these areas of what we call geographic atrophy, where the cells have died. And then in terms of active clinical trials that are ongoing at the Gavin Herbert Eye Institute at UCI, where I practice, there is one that Dr. Koopman, our chairman, is the principal investigator for in collaboration with a company called Ionis, that is targeting dry advanced macular degeneration. And I have a small clinical trial, which is actually focused primarily for looking for patients who are first to third generation Japanese backgrounds, to try this a newer medication that can actually be used not only in macular degeneration, but it also could be used in other diseases like retinal vein occlusion and diabetic retinopathy. So at this point, Novartis, the company, is only looking for people of first or third generation backgrounds. So what can a patient with macular degeneration expect? Well, first off, don't lose hope. No one gets a lot of comfort from knowing that things are so much better now than they were 20 years ago. But that's actually a pretty great thing, because science is accelerating, and there are many people whose visions we can truly sustain. And I think that we're going to be better and better at that over time. And also, we are living in a time of innovation where treatments that are completely unique and novel compared to what I've talked about so far will come to the fore. So science for AMD at UCI. So we have a very large and really quite impressive research division, PhD researchers in our Department of Ophthalmology at the Gavin Herbert Eye Institute, who are investigating systems pharmacology for early macular degeneration. We're also studying transplantation for people with late disease and some advanced imaging tools that will help us to understand what exactly is macular degeneration. So how many diseases is macular degeneration? Honestly, we don't really know. When we talk about phenotypes of macular degeneration, we're talking about how the disease looks when someone like me looks inside a person's eye. And if we look at these different AMD phenotypes, these would all be considered photographs of someone with intermediate macular degeneration. This one looks very different from this one, looks very different from this one. And these are the labels that we use to describe the appearance of drusen, the bumps underneath the retina. If you look at the histology, if you actually take a piece of this retina and look at it underneath a microscope, we can see that these bumps either occur underneath the foundation and appear like this, or they might have this layer around them underneath the foundation, or here this bump is actually above the foundation. So surely these things that we all call macular degeneration aren't really just one disease. And like I said earlier, these bumps are formed by the breakdown products of normal vision. So there are many chemical processes that allow normal vision, and not all the same chemical processes have to be affected in one person versus another person. So we need to understand what is the failing chemical process that is unique to a person that causes them to have an appearance like one of these three pictures. And actually the OCT images look very different in each of these pictures as well. The bumps underneath the retina can be very large, or underneath the foundation can be very large. They can be smaller and look more like this, or they can be on top of the foundation. So we are investigating advanced imaging, and these are some of the researchers who I work with. Josiah is in my lab, and then Chris Palczewski and Grazna Palczewska are my mentors, working with collaborators from Poland to develop cameras that look at the chemistry of the retina and try to understand what is the chemistry that's failing that causes macular degeneration. What I'm showing you here are OCT images of mice that have different genetic mutations. In fact, this mouse here, the Stargardt's mouse, is supposed to be simulating in some ways macular degeneration. But the reality is that a mouse never lives for 80 years. A mouse doesn't have a macula. So modeling a human disease that takes decades to occur in an animal that doesn't have a macula and doesn't live that long is not a great scenario. We can't really ideally have a great animal model for the disease. So the human is the best model for the disease. But look at this, this Stargardt's mouse and this Leber's congenital amaurosis mouse, their OCT images look so similar. You know, this one looks a little bit less grainy than these other images, but the layers of the retina are all so very similar. So this OCT test does not really identify a difference between these different diseases. And if we zoom in on this foundation layer, which is shown in this black box, we can use an advanced imaging tool called 2-photon imaging, and then we can look at individual cells underneath the retina. And now we can see that this normal, healthy foundation looks very different from this diseased foundation and this diseased foundation. All these little green dots have different sizes and distributions. And we can even look at how the chemicals inside these cells appear differently with different types of light. And we can use this other type of imaging called 2-photon lifetime imaging that allows us to see that there are really unique chemical signatures. And we are developing the technology now to perform this same type of imaging in a human subject. And right now, this is the instrument that we've built in my lab. And we don't have it up and running completely yet. We're fine-tuning it. We have appropriate approvals from our institutional review board to be able to image people's eyes. But as you can see, it's a very sophisticated optical tool. And this is Josiah, my postdoc, looking into the instrument. And we are able to get photos of the back of the eye. And we do anticipate that we will be able to use this technology to understand better what is the biochemistry. Because if we understand the biochemistry, then maybe we can actually intervene with the condition when people are in their 30s, 40s, and 50s. Maybe we can actually stop macular degeneration before it even begins. Another approach is something called systems pharmacology. And these are some of the researchers that are in our Center for Translational Vision Research who have pioneered this field for retina biology. systems pharmacology is kind of like what this picture shows us. I've shown you all these different injectable medications, which is kind of like this guy sticking a finger in one hole. But diseases are much more complex. Diseases can have multiple holes. So is there a way that we can use a combination of drugs to close all these holes and stop the disease? And so what this group of scientists have pioneered is the use of FDA-approved drugs at their lowest dose to try and stop progression of disease. And so we do have the dream that we will one day apply this approach to people with macular degeneration to stop the progression of their disease. So not only would people be able to benefit from the AREDS vitamins and the Mediterranean diet, but they can also have very low doses of FDA-approved medications to slow down the progression of disease or even halt it. And then finally, retinal transplantation. This is my graduate student and two of my collaborators in engineering and the Stem Cell Research Center, who we work together to try and make pieces of retina that we can put into a blind eye to try and restore vision. And so when we take a stem cell and we can actually cause it to develop into retinal tissue, we take these little stem cells, we make them form these little balls, and then we hold them in a petri dish for months and months and months while they develop from immature stem cells and develop into actual balls of retina. And the dream is that we can take these balls of retinal tissue to transplant them. But making these tissues, as you can see, requires months and months. And every 2 days, someone is going in there to take out the old fluid and put in new fluid to feed these tissues. It's a very labor-intensive process. And we can see that these balls of tissue, when they're 46 days old or a month and a half old, they can look like this on a very high resolution microscopy image. But by 5 months old, they have this layered structure, very much like you would see in a retina, like those OCT images where we see the layers of the retina. And we can actually look at the function of individual cells using one of these 2-photon imaging techniques. However, what we've done is we've tried to make the manufacturing of these balls of tissue automated and to try and reduce heterogeneity or variability in manufacturing these, what we dream will be transplantable tissues. And so we've made this, what we call a microfluidic bioreactor for maintaining organoids, these retinal tissues in each of these little blue dots. And so fluid flows in, and all these little wells get fed and fluid flows out. And this occurs continuously without any human influences. So rather than a human spending maybe 3 hours a week, they can spend 3 hours every 2 or 3 months with this process. And so in animals, this is a healthy rat, and this is the OCT image of the healthy rat. In a rat that has a disease where the photoreceptors die, we can try and transplant one of these balls of tissue, and we can see here, this is the transplant underneath the retina. And we've seen these animals regain some vision in areas where when they had no vision at all. So this is the dream, that we can refine this process and eventually be able to help even people who have permanently lost vision. So the goal is to stop macular degeneration from forming, but if it does form, slow it down. And if it gets to its most advanced form, hopefully be able to restore some more vision for people. And this is a photograph of our eye institute. These are all the faculty in our department that are clinicians and scientists and clinician scientists. And so we have a really impressive cadre of clinicians and scientists who work together very closely to try and help people preserve and even restore their vision, and also develop new technologies that will be usable in the future to help people as well. So with that, I'll take any questions if there are any. I'll stop sharing my slides for now, and I'm going to look and see in the chat if there are some. So I see that when I'm in a store looking for items and can't see, the people look at me as I was demented and tell me, you can see, but I do not see. That's why I ask, are there any patches, signs I can wear to show people that I do not see very much? There aren't any type of prescription patches, but certainly one could wear a sign, or a necklace that, or even a bracelet that could have a notification to people, or hopefully people are kind enough that if you tell them that you can't see, they will believe you. I have another question here. Does having vitreous detachment increase your odds of developing macular degeneration? It doesn't, no. Vitreous detachment is a normal age-related process that occurs where the vitreous jelly separates from the back of the eye, and people may sometimes see floaters when this occurs. Whenever someone has new floaters, they should be examined to make sure that when the vitreous is separating from the back of the eye, it doesn't also cause a tear in the retina. But no, it will not accelerate macular degeneration or increase the risk of it occurring. Another question is it known how the injected medications work at the molecular level? That is, what proteins and or genes are activated or inactivated? So certainly these injectable medications, they're very similar to something we call antibodies, the things that attack foreign viruses or bacteria that can get into the body. They are targeted towards something called vascular endothelial growth factor, VEGF. And they try to reduce the interaction between VEGF and the protein receptors that respond to VEGF. So vascular endothelial growth factor, if you think about vascular endothelium, those are the cells inside blood vessels. Growth factors are things that make things grow. And if you stop the cells that are inside blood vessels from growing, you can stop new blood vessels from growing underneath the retina, bleeding and causing vision loss. Let me see here, I think. And then certainly when you modulate vascular endothelial growth factor, you can change the proteins that are controlled by it as well. Should I be worried if my optic nerve is enlarged? My dad had wet macular degeneration. I do have floaters. An enlarged optic nerve can be a normal physiology, kind of like having large ears or a large nose. And it certainly is not associated with an increased risk of macular degeneration. However, family history is. So if you do have a family history and you're over the age of 55 or 60, it probably isn't a bad idea to get a baseline examination. And also, I would be on a Mediterranean diet. And actually, I am mostly. My dad had macular degeneration. And so I know that I'm very likely to have it as well in my future. Another question here. So don't use the AREDS2 vitamins if you don't have wet macular degeneration. No, actually, the AREDS2 vitamins are indicated for people with intermediate and beyond macular degeneration. So if you have intermediate macular degeneration, you should have it. You should be on the AREDS2 vitamins. If you have early macular degeneration, there hasn't been any shown benefit. Some people have studied this, and some people have shown that they can make things worse. Some people have shown that they can make things better. But the AREDS2 studies did not show, the AREDS1 and AREDS2 studies did not show a benefit for early macular degeneration. Do you have to be diagnosed with AMD to be part of the study? Also, why are they looking for Japanese first and third generation? In terms of, to be part of the study, you do have to have the diagnosis and you have to have the appropriate stage of the disease. So wet macular degeneration in the context of the study that's looking for Japanese first and third generation, or just dry macular degeneration for the other study. Now, the Novartis who's sponsoring the study, they've completed so this is actually at the safety phase, so making sure that the medication is safe for administration into the eye. And they've completed their study in the broader population, but they have a specific interest for the study medication, which I'm not allowed to discuss specifically, but in Japanese populations, because, just like, we all have different hair color and eye color and even skin color, there is some difference in biology and different ethnicities. So they, in this case, are particularly interested in Japanese population. I have another one. Thank you. You're very welcome. What is the difference between vitreous hemorrhage versus wet macular degeneration? So vitreous hemorrhage is something that can occur where you have bleeding inside the volume of the eye, where there's actually blood floating around, kind of like a snow globe being shaken up. And that can occur from macular degeneration. I've only ever had one of my patients who ever developed vitreous hemorrhage with macular degeneration, with wet macular degeneration. But it's more typically associated with trauma, diabetic retinopathy, retinal vein occlusion, which is like a stroke. Wet macular degeneration is where you can have bleeding, but it's usually in or underneath the retina. It usually is not so severe that it actually breaks through the retina and goes into the vitreous space or the cavity of the eyeball itself. I have macular degeneration and glaucoma and have a slipped lens. What can you do? well, we can certainly help you. And I think that, before I claim that we can help you, we have to examine you to make sure that that your eye is in a stable situation to be helped. If you have macular degeneration, I hope that you're following with a retina specialist somewhere. If you have glaucoma, I hope that you're being seen by a glaucoma specialist as well. A lens that is slipped, if it's slipped to the point where it's floating around inside the eye, we typically recommend removing it from the eye and replacing it with another lens that is fixed and stable. And we have some advanced surgical techniques that can be used for that. Are AREDs without zinc superior to those containing it? No. Zinc has been shown to be beneficial in the context of macular degeneration. My wife is a third-generation Japanese American with glaucoma, but doesn't currently have AMD. Should she arrange to be examined? So this study is specifically for people with who have either wet macular degeneration, diabetic retinopathy, or have had a retinal vein occlusion. So unless she has one of these diagnoses, she wouldn't be able to participate in the study. But if she has glaucoma, she really should be followed by a glaucoma specialist. And I hope she doesn't ever develop AMD. Interestingly enough, AMD is a condition that was historically more associated with white folks that look like me. And nowadays, with the Western diet being as prevalent as it is, it actually has kind of crept more into other ethnic groups as well. Can AREDS 2 prevent AMD? So AREDS 2 has not been shown to be beneficial in people without macular degeneration or even with early macular degeneration. However, a Mediterranean diet is, I would say, beneficial in this context as well. It has been beneficial in people with early macular degeneration, preventing them from progressing or delaying their progression to intermediate. Besides the Mediterranean diet, are there any eye exercises that one can follow to maintain healthy eyes? No eye exercises in particular. I do recommend that people wear sunglasses. Sunglasses block out some of the shorter wavelengths of light and reduce some of the stresses that occur with bright lights. But even this clinical studies involving the use of glasses aren't completely conclusive yet. But we live in Southern California. We have a lot of bright light. I would encourage you. I think my optometrist suggested taking the AREDS 2 for retinal health. I don't agree. There's a lot of eye products that are marketed to try and improve eye health. The science that supports it isn't quite as robust as we would like. I'm not taking any of the vitamins, and I have a risk factor for macular degeneration. So if that answers your question, if you feel like it helps you in terms of the placebo effect, maybe there's a benefit there. And the placebo effect can be very real in some cases. Can you prevent AMD with diet alone? Not entirely. People who develop AMD do have, and there are genetic risk genes that are associated with an increased risk. And so even having lived a perfect life, not smoking and having a perfect diet, macular degeneration still can develop just because of our genes. For people who have that risk, and if they're smokers and they've stopped smoking, hats off to you. And if you have that risk and you've been having a healthy diet and not smoking your whole life, hats off to you as well. It's you've really done you truly have given yourself a miracle by doing that. And what treatments are available for adult high myopes with loss in contrast sensitivity and optic atrophy? So high myopia is a completely different condition from macular degeneration. It's a very structural disease where the eye elongates over time. And so there can be some very similar appearances of the back of the eye in people with myopia as people with age-related macular degeneration. But at this point, we don't recommend the eye vitamins for macular degeneration for people with high myopia. Although I think that probably having a Western diet, if it doesn't help your high myopia, at least it'll help with any possibility of heart disease as well. I mean, not the Western diet, sorry, the Mediterranean diet. I hope I didn't misspeak there. And it looks like I've come to the bottom of the questions. Lowering cholesterol with niacin and statins, does it help significantly? Statins are something that are still under investigation. for macular degeneration. With some of these studies, I talked a little bit about macular degeneration probably being a variety of different diseases that we just haven't broken up into their specific biochemical disorder. And so I would not be surprised if statins help a very specific population or group of people with macular degeneration. And so it may be that, and also maybe niacin could as well. This is where, kind of a systems pharmacology approach, where using a combination of different things and actually understanding what is causing macular degeneration could give us information to help everybody in a unique and tailored fashion in the future. And I think that, at the end of my career, hopefully I'll be practicing for another 30 years or so. I hope that I'm not having the same conversations that I'm having with my patients today. It's one of the hardest things is as an ophthalmologist is to talk about macular degeneration and the advanced forms particularly. I'm completely committed to it, to finding solutions to this, and I know that the scientists that I work with are equally committed. We're all kind of driven by this, and so I think that we will see a revolution over the course of my career, and that'll continue forever. I was diagnosed with macular degeneration a few years ago. I recently was seen by a different doctor and was told no. Should I be seen by a specialist to make sure? Whenever there's a question about a diagnosis, I think that it's most important that the patient feels that they find the answers that they're looking for. And so if you have any questions or any doubt at all, I encourage you to get a second opinion. If it's with a specialist, 100% agree with that as well. Even my patients who I see in clinic, if anybody has any questions, I will never take offense to someone getting a second opinion. I think that patients come first, and you need to make sure that you feel comfortable with the doctors that are providing your care, and that you are getting all your questions answered, and there isn't too much ambiguity. Are there major differences among the AMD medications, Eylea, Avastin, Lucentis? So this is something that has been studied pretty extensively. And so the general observation is so in clinical trials, there can be some very subtle differences where one may be able to dry the fluid a little bit more than the other. However, when we look at large populations, Medicare claims, and looking at injections in people with macular degeneration, clinical trials are in no way the same as coming to see me or any of my colleagues around the country, because we don't actually conform to a clinical trial protocol. A clinical trial protocol involves having a clinical trialist, a coordinator who actually calls the patients and makes sure that they're coming back exactly on the schedule for the injections. And while we try our very best to mirror what the clinical trials have shown us, we just don't. And we see that in large populations around the country, around the world. There was something to maybe 10 years ago, I saw that Italy has the fewest injections for macular degeneration than any other European country per patient with macular. And of course, there's multiple social factors that can influence this. Fortunately, Italy has a Mediterranean diet, so maybe they're a little bit luckier than other parts of Northern Europe. But the reality is that in day-to-day clinical practice, which is what every patient has unless you're enrolled in a clinical study, these different medications are so equivalent. If it was me, I would just be saying, hey, I know I need one of these medications, make sure I get one of them. That's my personal preference. And I hope that answers your question. Let's see if there are any more. Everybody, you're all very welcome. Thank you for coming and attending today. If you have any questions, please feel free to reach out to me. And if you have any other any eye conditions, and you're looking for care, I can help you connect with someone who can provide you with the care that you're looking for. And I hope that everybody enjoys some good Greek food or Mediterranean food at your next meal. Thank you for your time tonight.
Thank you, Dr. Browne. I think it was a fabulous presentation. Everybody seems to have enjoyed it. For those of you who are interested in other of our upcoming lectures, next month on Tuesday, May 10th, we have a lecture on neuro-ophthalmology featuring Dr. Vivek Patel. I've put the website link in the chat where you can go to register for that and other upcoming lectures. If you have any questions, feel free to get in touch. Thank you so much for joining us. Have a good evening, and we hope to see you next time.